Hi everyone. I'm just going to wait for everybody to filter in. Okay, Brill. So we'll get started whilst everyone else filters in. So thank you everyone and welcome to the first supporter session of the year. We're really grateful that you guys are all joining us and we're super excited to have Dr. Dimitry Sayenko, the Associate Professor at Houston Methodist. So Dr. Sayenko's work focuses on the mechanisms and effects of spinal neuromodulation in the sensory motor recovery after neurological disorders and injuries, and this includes stroke and spinal cord injury. So his talk today is going to be titled Spinal Stimulation After Paralysis, Mechanistic Insights and Functional Gains. So I'll hand over to you.
Well, hello. Thank you very much. It's been a real honor to present to such a group, and this is not my first time, so there would be a little bit of an overlap. And just to get things rolling with my previous presentation, but it will be probably new for those who just watch it first time. So. Yes, my name is Dimitry Sayenko, and I work in Houston Methodist in Texas, USA, and for about, I think, 30 years, I've been researching sensory motor control, and the last couple of decades, I'm very interested in spinal neuromodulation, and I'm very excited to share some of my data and the lab progress that we were doing through these years. So just to get started, let me remind you what do we know from research standpoint, electrophysiology standpoint about spinal cord injury. With the intact spinal cord, the signals go from the brain to the muscles and from periphery to the brain. They travel through the spinal cord. But in case of spinal cord injury, we have disrupted communication with the brain. There are several things to remember, and they would be basically the cornerstone of my talk and my presentation and my research at whole. So first of all, um, there are different clinical presentation depending on the level of the injury, right? Cervical injury lead to quadriplegia, lower injury in the spinal cord lead to paraplegia. But one of the most critical things to remember that in almost 80% of people with spinal cord injury, the anatomical connections still exist through the spinal cord, which means that they may not be able to produce any motion, or they may not be able to sense certain stimuli below the lesion. But anatomically, there are still pathways, all those subfunctional pathways. And another thing is that below the lesion, the spinal circuitry, which is a network of neurons and the like different complicated connections run into antagonist and agonist muscles, the reflex loops, those spinal circuitry remain functional. So the premise is if we stimulate below the lesion, and we activate those interneuronal networks, we can enable movements. And one of the first paper which demonstrated its effects in preclinical models was a paper coming from UCLA with first author Gregor Kurtin, whom lots of you know now has very well-developed research in the area of spinal neuromodulation, and Reggie Edgerton, who without any exaggeration, can be considered as a godfather of the area of spinal neuromodulation. Now, the premise is that in intact spinal cord, we have these connections. We have connections of interneurons, which are sometimes organized in the networks, sometimes being termed as central pattern generator, which can produce automatic movements. All they need is descending command from the brain about initiation of the movement, and regular afferent inputs coming to these networks. And then an example is we think to start walking. We start walking, and then once we start stepping, the signals from periphery help spinal cord to generate rhythmic output in agonist and antagonist muscles. In case of spinal cord injury, the connection from the brain is lost. The brain signals cannot reach to the network and initiate the movement, but also the network is quite disorganized, and afferent information from periphery cannot generate functionally relevant movements. We can still see certain bursts of muscle activity, for instance, during manual locomotor training, manual assisted locomotor training after spinal cord injury on a treadmill, but most likely the muscle output would be dysfunctional, disorganized, and functionally irrelevant. However, with spinal stimulation, we can re-engage the networks, spinal networks, so that they become susceptible to spinal stimulation, and then they start being capable to produce rhythmic motions. What do we know about spinal neuromodulation right now? We know that after spinal cord injury, even with time, there is a very little expectation in performance, in functional performance, and in gain of function. However, if we deliver spinal neuromodulation, we also learned that we can immediately bump up this performance and produce movements that were not observed before. So we can observe it, for instance, during transcutaneous spinal stimulation and grasp movement. We can even observe it in a person after clinically complete paralysis. First time we start stimulating the epidural lumbar spinal cord, the person is able to generate independent standing. Obviously, it was not possible without spinal stimulation. We also learned that with time of training, we can receive even more gains, even more functional performance, so that the same person as shown here is able to produce locomotor behavior, locomotor ambulation. We can see much better, much more impressive standing, for instance, using transcutaneous spinal stimulation. And even after cervical spinal cord injury, there are reports that people are able to ambulate in the presence of spinal stimulation. In lots of cases, we know that spinal stimulation can be, the intensity of spinal stimulation can be decreased with time of training, with progression of the training. And there are a few reports indicating that it can be even turned off and we still see impressive function. Now, a couple of things that I'm going to use in my presentation and my research. These terms, they're a little bit subjective, but I hope you will appreciate their meaning. So enabling effects of spinal neuromodulation, it means that if we stimulate stereotypically, so not associating stimuli and intensity and frequency to each movement, but in the presence of such stimulation, non-specific stimulation, person is able to choose to ambulate or change their pace or stand or stop walking. So these effects, let's call them enabling effects of spinal stimulation. And this is an example of study that we performed together in Mayo Clinic. And these are some examples of performance enabling effects of spinal stimulation in my laboratory, where this person with over 20 years of paralysis was implanted with epidural stimulation, and you can see the performance during sitting as well as during standing. So those parameters were, again, non-specific, not tailored to the function. They were just, we created this cloud of current, and then the spinal cord was engaged enough to be receptive to the motor intent and generate desired function. And this is contrasted with inducing effect of spinal stimulation. Inducing effects were introduced by Dr. Courtine in Switzerland. And the idea is that we can decode, we can decompose the signals, for instance, during locomotion in a non-injured person. And then we can see that different leg muscles are activated differently at different time. So if we now deliver spinal stimulation specifically to motor pools, projecting to those muscles of interest in different cycle of the stepping, then we can produce stepping, and that initially they may look a little bit robotic, but um, the work showed that was very impressive performance across many participants during overground stepping, and these are again induced effects. Now, what about non-invasive approach? Can we achieve anything, any results like this using transcutaneous spinal stimulation? Because in theory, if we apply the electrical field above the spinal cord, we can still activate those strategic locations of motor neurons projecting to legs and um, generate um, activation in the interneuronal network in these locations. So this is an example of experiment performed now in our lab where we used transcutaneous spinal stimulation in person with sensory and motor complete paralysis. And you can see we could also achieve independent standing and extension in the knees and quite independent balance in the hips. We also can apply this stimulation during training with exoskeleton, right? The idea here is to repair this cycle, and the premise was that the brain would generate descending commands. They would go through the spinal cord. We will amplify the spinal cord stimuli and signals. They would reach to the muscles, and the robotic exoskeleton will promote these repetitive motions necessary for successful rehabilitation. And then the proprioception, hopefully some sensory information would go to the brain. The brain will generate the signals, and then the cycle repeats. However, what we noticed is there is definitely there was a caveat here, right? First, we are dealing with two technologies. They are quite independent as we speak, exoskeleton technology and spinal stimulation. So in a way, exoskeleton will still drive stepping forward of the person, regardless of spinal stimulation. And our intention was to see if we can monitor the forces, if we can also look in the muscle activation patterns during spinal stimulation and see if there is any difference of locomotion with stimulation or without stimulation of stepping an exoskeleton. And what we found is that if we apply spinal stimulation in continuous or so-called enabling matter, we don't see much of the gains. And muscle activity, yes, we see certain promotion of muscle activity, but that would be more even probably occluding the motor output rather than helping, because there would be lots of co-contractions across agonist and antagonist muscles, and the overall performance with continuous spinal stimulation didn't really change. So we decided, what if we apply pattern spinal stimulation, sort of mimicking this inducing effects of epidural stimulation shown earlier. So we decided to apply spinal stimulation in a sequence of diagonal arrangement. So we would apply stimulation through, if you see my mouse, lateral electrodes and on contralateral sides, and then we will repeat another cycle using another step cycle. So. And one important thing is that we were trying to, again, marry these two technologies. So we applied a force pressure sensor under the participants' feet. So every time when they would have a toe off, get their foot off the ground, the stimulation at a given diagonal would be turned on, and we saw quite better performance. And I will show you in a second how we see it outside of this exoskeleton. So here in this video, this is another person with the motor and sensory complete paralysis. His injury was at T4 level, ASIA A, 2.5 years post-paralysis, but you can see that the muscle atrophy is already very strong. So here on these videos, let's take a look at enabling versus inducing effects. So on the two left videos, you would see that how stimulation is delivered at the midline. This is T11, T12 level of stimulation. We delivered it at 30 hertz with a given intensity, with a certain intensity, and we asked the person to swing their legs while we deliver the stimulation. And on the video on the right, you would see this sequential stimulation, and the person heard beeping sounds, and every time when he would hear the beep, he would try to swing different legs. So let's see. I hope you would appreciate the difference in performance. So here is continuous stimulation. So we see some movements. My video is a little bit lagging, but I hope you would see it. But if you look at the video on the right, you could see that the amplitude of the movement, the range of the motion is much higher in the presence of this pattern stimulation. Which again brought us to the point that it's not just the fact of spinal stimulation, it's the matter how we deliver it. And I hope this example shows you that the location really matters. Now, we try to apply the same concept for the upper limbs. Again, the same idea. We would try to repair this cycle. We would use upper limb robotic exoskeleton, and the premise was that we can reach out to motor pools projecting to upper limb muscles by stimulating at different locations above the spinal cord, hoping that the exoskeleton would promote different isolated motions like elbow flexion, extension, wrist flexion, extension, pronation, supination. And then if we deliver strategically spinal stimulation in different areas, we would predominantly activate particular muscles responsible for this movement. Think like it sounds great, right, in theory, but in fact, we hit the wall here. Why? Because it turned out that cervical spinal cord is organized quite differently compared to lumbar spinal cord. And even if we deliver spinal stimulation at 4 different locations along the cervical spine, we cannot really exclusively activate muscles of interest. So for instance, if we stimulate at the most rostral location, we would hope that, well, yes, we would activate predominantly biceps and triceps and then promote reaching, for instance, or pulling movements, right? But turned out that if we stimulate at this location, about 90% we also activate, 90% probability of us activating hand muscles. Another way around, if we activate as low as possible, hoping to target the hand muscles, there would be activation of everything at the same time. And another problem here was the tolerance of stimulation. So we learned, and I will show you in a couple of more slides, that intensity of stimulation really matters to get the right effects. But when we deliver cervical spinal stimulation, it is very hard to reach to the level of therapeutic dose window because of the poor tolerance of cervical stimulation. Now, we talked about importance of location. What other factors may drive the effect of spinal stimulation? And I presented this data last time, but I will repeat very briefly. So we did this study in large animals, in pigs, and we tried to combine the signals from the brain and the spinal cord, like trying to see what factors would drive the best integration, best synergistic effects between the, again, cortical stimulation and spinal stimulation. And we realized that if we stimulate very close, if we deliver spinal stimulation close to motor threshold, the effects the facilitatory effects, potentiation effects, are the best. They 400% higher than if we deliver stimulation at too low intensity or too high intensity. So it brought us to the conclusion that, okay, now location matters where we stimulate, but also intensity matters. And the intensity must be properly titrated. We cannot stimulate too low because we don't have that much of the functional gains if we stimulate at low intensity. And we also cannot bring the stimulation too high. We cannot just always induce the effects and drive the function, because maybe we would see the function, but this integration of descending pulses with spinal network would be probably minimized. So this is my intermediate conclusion here, that we demonstrated that transcutaneous spinal stimulation might share the same routes as epidural spinal stimulation, but the mechanisms might be still different between those two. I hope you saw the demonstration of enabling and inducing effects of spinal stimulation, both epidural and transcutaneous. Then physiological and functional effects depend on location and intensity. And it all brings us to the point that quantification and standardization of the outcomes are required to properly titrate stimulation, to assign it, to administer it, and to evaluate its effects. So the point I'm trying to make here is that the mechanistic insights from lumbar spinal stimulation cannot be directly applied for cervical spinal stimulation. We see limited enabling effects of cervical epidural stimulation, of cervical stimulation at all. We think that the stimulation must be timed to different tasks which are intended from upper limbs, which makes sense. Our upper limbs, our hand and arms are under more direct cortical control, brain control. So we actually have to rather think when we are performing individual movements. And this is contrasted with lower limb movements, lower limb performance, when we don't have to really activate individual muscles in the legs to do stepping or standing. So yes, and as I said, that the cervical spinal circuitry probably is organized a little different, to say the least, from lumbar circuitry. And it all can be translated to this complicated animation or schematic, which you don't have to remember. Is just we were trying to demonstrate here that the effects of cervical stimulation may affect on the amplitude of delivery, intensity of delivery, frequency of delivery, and level of delivery. So all these three factors may play important role when we expect any functional gains from cervical spinal stimulation. This is a brief summary here. So if we are talking about precision, sensation, activation profile, and motor output, and clinical impact, this is based on our observations and the experiments that we performed using transcutaneous stimulation and epidural stimulation. You can see there are quite there's quite difference between non-invasive and invasive approaches. So I'm wrapping up, and basically, the point that I would really try to make is that neuromodulation strategies need to be individualized. It is very hard to apply them in a fit one all paradigm. So it has to be individually tailored to individual injury or tolerance or level of performance. We also saw that epidural spinal stimulation provides greater selectivity, and it is much more flexible than transcutaneous methods. We could see that epidural spinal stimulation can enable a modulation of respiratory function, which is great news to me because it is still motor control, but it goes beyond lower limb and upper limb, promoting such functions as respiratory. I think it's a huge impact on the community and moving forward. And then, of course, I'm advocating deep investigation, not only the mechanisms, but also quantification and standardization of the outcomes. Because if we able to describe them in rigorous manner, then we know what we are doing, and it will just help us to improve the methods of delivery. And of course, there are still questions. We don't know the full spectrum of interaction of spinal stimulation with descending pathways or ascending pathways, and lots of this work um, very depend on the morphological exploration, which is very difficult in humans. So this is just last slide appreciation of my lab, my collaborators, the funding agencies, and just wanted to mention to you that we are continuously recruiting participants for our trials with both non-invasive and non-invasive and invasive stimulation, targeting both upper limb and lower limb functions. So these studies are performed in Houston, and they usually up to 4 months long. But we may have some mechanisms to support, at least partially, willing volunteers and individuals who want to participate in this trial. So if you're interested, please reach out to me. Here is my email, but also I'm pretty sure that my contact information would be available otherwise. So this is it from me today, and I'm happy to take any questions.
Thank you. Thank you, Dimitry, for such a great talk. I know this sort of area of research is an especially exciting and interesting area for all our supporters. So I'm sure they'll have plenty of questions lined up for you. And for those of you guys who do want to ask some questions, you'll see at the bottom of the screen there is a box that says Q&A. You are more than welcome to click that and send some questions through. I can see we've already got a couple. So first of all, we've got a question from Vincent who asks, what effects, if any, are you seeing on bowel, bladder, and sexual function?
Well, we don't explore this function systematically. There are reports, but we don't perform systematic, for instance, urodynamic to get quantitative assessment. We see, for instance, that there was this participant in the beginning of my presentation who had very good effects on the trunk extension during sitting. You probably remember her 20 years post-injury. And we saw her recently, and she is really praising the effects on bowel function. So her bowel program reduced significantly in the presence of stimulation. We know that spinal stimulation can increase tone, including tone in bladder, which it can go different ways. On the one hand, the participants need to, for instance, use the restroom more often during our sessions. On the other hand, they can report that there is less of residual volume in the bladder. Sexual function, we are trying to ask them, but so far we didn't hear many of the evidence that it is changing.
Okay, right, thank you. And a question from Peter asking if autonomic dysreflexia is a contraindication for spinal cord stimulation.
So in our inclusion criteria, we say, well, rather exclusion criteria, we say people with uncompensated AD. So those who once in a while have it, they like we need to probably have an additional screening for them. But overall, during our trials, I think I saw just once a case of autonomic dysreflexia, which was actually we couldn't even explain because we had it once and then we worked with this participant several weeks after and we never saw it before.
Right, thank you. And we've got some questions about scar tissue. We've got one from Christine who asks, does scar tissue interfere with stimulation effects?
We didn't see much of the effects of scar tissue. I'm thinking that the question is regarding the scar tissue on the skin, right, on the back, and as a contraindication for transcutaneous spinal stimulation. This is how I'm interpreting this. So if it is the case, then we didn't see much of the effects of this scar tissue on the effects of transcutaneous spinal stimulation. On the other hand, as well as hardware. So this is another question that I'm getting a lot. If the hardware can be on the way of transcutaneous spinal stimulation. We didn't see much of the effects of hardware on this on the spinal stimulation. On the other hand, there is scar tissue, for instance, from infection or previous interventions in dura, already in a epidural space. And that was one of the reasons why, for instance, our surgeon was not able to implant the array at the location where we initially wanted him to go, right? So he kind of like stuck the bottom of the C6, and then he couldn't put the array due to this scar tissue. So this is sort of like a technical reality and limiting factor of epidural spinal stimulation. And unfortunately, it is very hard to screen beforehand. So before the surgeon starts the surgery, it's impossible, almost impossible to predict whether it would be an obstacle or not.
Great, thank you. And we've got a question from Patrick who asks, are the patients picking up any additional feeling or sensation, or is it just movement?
I'm so glad that you asked this, Patrick. So this is something that is very important, and I didn't mention it. When we started stimulating, I'm talking about cervical epidural stimulation, our first participant. So he was first for epidural stimulation trial, but as I mentioned, he participated before with transcutaneous spinal stimulation trial. So he knew very well how it feels, spinal stimulation. Now, imagine, so first time after surgery, we put these sensors to record muscle activity on his forearms, and we started stimulating cervically, epidurally. And then this person looks in his arms and forearms, and he is asking, are you stimulating? What are you doing with my arms? Because I'm feeling them right now. So he loved this feeling. He described it as surgeon energy, something like this, through his arms. So he definitely felt it. And also we did the INSCI, the Asia exam after the intervention, and we saw quite impressive improvement in sensation after with the stimulation off. So it is very interesting that when we turn on stimulation, they feel it sort of like everywhere, and it actually dampen a little bit the sensory manipulation. But once it's off, it looks like there is certain improvement, certain effects of this on sensory function.
Yeah, and to add to that, Helene asks what amount of movement is carried over after the stimulation is turned off and for how long? So this is movement.
So far, I think the best way to answer this is that the effects are mostly prominent during stimulation. So when the stimulation is on, we can see the effects. We can see improvement of the movements. When the stimulation is off, there might be still certain changes in muscle tone, but not the movements itself. But I'm thinking about it from the standpoint of reorganization, plasticity, any restoration, regrowth. And as of now, I don't think it's actually bad news that we see effects only when we stimulate. Because imagine if we're talking about, again, axonal regrowth, for instance, right? I'm not sure we want to promote it uncontrollably, because if we're talking about certain regrowth of neural structures in the spinal cord, then we will not only talk in the context of motor performance that would be also related to pain or spasms. So we actually, I'm not sure we want it. Most conservatively and most, I think, effectively, turn on stimulation, get some function that you want, turn it off, and then just keep building the connection with the brain or motor performance during stimulation. So that would be my strategy.
Okay. And Craig has asked, is there any data on negative effects of any type of stimulation? So in particular, like nerve pain or increased spasms, which have been recorded.
We have reports. We are trying to investigate the effects on spasms and muscle tone, or rather monitor those effects. And it really depends from subject to subject because, for instance, some people can they would come to a session like next day and they said, okay, today I feel more higher muscle tone than yesterday. So after this session, the muscle tone is increased. We cannot fully attribute it to spinal stimulation because residual effects from the previous session can include muscle fatigue, for instance, right? We really want our participants to work hard and sweat during the training. So this also may contribute to increased muscle spasms. On the other hand, we saw and we heard from our participants lots of time that at the very end of the session, so let's say we have one session, they felt more flaccid, so they have less muscle tone immediately after the session. Then probably by the end of the day, that would be increased muscle tone. Then that would be probably lasting about 24 hours, and then it will come back to normal.
Okay. And David is asking about some new external stim approaches are now FDA approved or working on approval that target upper limb improvements. Do you have any thoughts?
So, so there are definitely several trials and companies and approaches who are going currently through the FDA approval. For instance, transcutaneous cervical stimulation. The our trials, they also in a way FDA approved, right? Because we are using pain stimulators, so stimulators that are used to treat neuropathic pain, but we apply them in people with spinal cord injury for specifically sensory motor restoration. So for us to perform these trials, we need to get off-label approval from the FDA. So FDA investigates it with high scrutiny, evaluates if it is safe or not, and then they give us the permission to use this off-label. Because this is research and we are not trying to commercialize anything, um, we don't go through the FDA approval route to use those devices commercially. But we are trying to, my goal is to investigate again the effects and mechanisms, how it works. So hopefully we can basically decide what works, what not, and how to make it work better. So for other companies to work towards FDA approval.
Thank you. We've got lots of questions asking about whether or not you've got any international collaborations or partnerships which would allow people from countries outside of the USA to get involved with your trials or studies.
So, well, thank you for this question. International collaboration. Well, I'm always up for collaboration. I love collaboration in terms of science, in terms of research, and other institutions. But if the question is about folks who want to try some of these interventions and consider coming to the US. We actually have a mechanism for that. Again, so I suggest them to reach out to me. It's a little bit, of course, complicated because they would need to be accommodated properly and then have certain health insurance here. But again, so it's a little bit case by case, and we sort of have a little bit of experience with this. So just let them reach out to me, and then we can discuss it in more detail.
Okay, that's great. Thank you. I can see we've still got loads of questions coming in. I am trying my best to get through them all. But if for some reason I don't manage to get your question answered, please feel free to send us an email and we'll do our best to get back to you. I appreciate that there's not a lot of time left on the webinar. So final few questions. Craig asks, have you seen any improvements from stimulation in people who have retained a large amount of tone in their lower limbs?
Um, improvement from cervical
Uh,
stimulation?
he just says stimulation. He doesn't specify.
So, well, it is a consensus basically that it's better higher tone than no tone for to sort of predict and forecast the functional gains. So, if there is a tone, most likely actually it means that there are those residual connections that can be harnessed, connections, descending connections, and leveraged to the function. So, to me, higher tone is actually good news, and we can try to build up on this and leverage it either to stand-in or some other meaningful functions. So it's better than no tone. I'm hoping I'm answering the question.
Sure, thank you. And Fatiha asks, is there any difference on the age of the patient or time post-injury in terms of how well they respond?
You know, I'm sure it may have some effects, but we didn't systematically investigate it. We have pretty wide range of people. They are limited. As of now, the lowest age, because again, we had to go through the FDA process, and FDA wouldn't allow us to work on anyone younger than 22 years old. On the other hand, we we are limited. We limited a little bit the high age by 65 or 70 years old, because we try to investigate changes in the brain, for instance, during spinal stimulation. I didn't mention about our neuroimaging component, where we stimulate in the an MRI, and we are trying to get functional MRI of the brain during stimulation to see if there is any reorganization there or any changes during stimulation. So so between 22, let's say, and 65, and we have people with injury 2 years post-injury, 20 years post-injury. So, I mean, of course, the sooner post-injury is the better, probably because of the preserved muscles. Whether there is direct effect of age at the time of the injury, we didn't investigate it.
Sure. So I can see a lot of people are asking for your email address, Dimitry. Just for those who are asking, it is on the bottom right-hand side of the screen. I know
Uh,
some people are really keen to get involved in the studies.
right here.
Yeah, there you go.
I'm not going to try to spell it because it will take the rest of the time.
No, I will give people a second to kind of note that down. So in terms of questions, we'll do one last question whilst people note down the email address. Um, Let me have a little look. Um, I think somebody has asked, it's Laurie, who asks, are individuals that have a baclofen pump excluded from spinal stimulation?
Not at all. Well, it depends where the baclofen pump is, but no, we currently have the mechanism in place to enroll them in the study as well.
Okay, that's great. Thank you so much, Dimitri, for your time. I hope you guys have found it useful as well. Thank you so much for joining us, and sorry to those of you whose questions I wasn't able to get to. Please feel free, if you do want to reach out, to drop us an email on research@spinal-research.org. Have a lovely rest of your evening or afternoon in your case, Dimitri, and thank you again so much for your time and for your presentation.
Thank you so much. That was fun. Thank you.
Thanks. Bye.